Thank you for joining, everyone. I have a little bit of building work going on in my house, so if something starts being very loud, please someone just pipe up and tell me, and I'll switch to my headphone and microphone. Just the microphone on my laptop's a lot better. Um, I'm going to have a chat about shock. So obviously, shock's a critical condition. It's very common in intensive care, and it's a condition that we need prompt recognition intervention. Hopefully this is actually going to let me do it properly. It is, okay. So things I wanted to cover and kind of questions as part of this is kind of go over what actually is shock, and try and give a definition or help for those that are coming up to an exam. What is the underpinning physiology of shock? How can we then further subdivide shock into different categories? Why am I talking about boilers when I get to that point? And then how can I actually use this, and particularly a little touch on what about sepsis, because I think even though it doesn't fit quite neatly into these definitions, and I think it kind of demonstrates some other things better. We'll get to that when we get to it. So first thought is, what really is shock? So when we think about shock, I think most people would picture a monitor that looks something like this and a patient that looks pretty terrible in the bed in front of us. We use the term itself in many contexts. So, we talk about emotional shock, but then from the physical time, it's quite all-encompassing. But there's some typical features, and I think the first one most people would say and think about is hypotension. But that doesn't necessarily always have to be there to define shock. Autonomic responses tend to be the next things we think about. So the tachypneic, sweating, tachycardic patient in front of us, looking quite pale, starting to get skin changes and looking cool or mottled, but again, not always, depending on the cause. And then, why do we care about it? Well, it has implications for end organ dysfunction. So altered mental state, whether that's acutely agitated, anxious, or becoming unconscious, oliguria, renal failure, liver failure, and the etc. And mortality from unrecognised, untreated shock is obviously very high. Something that comes up more for kind of ED folks amongst us is the shock index, which is probably more useful for the hypovolemic and traumatic patients, but I find it quite useful as a fallback point for myself, is simply heart rate divided by systolic blood pressure. So a normal one is somewhere between 0.5 and 0.7. So anything over 1, you're into at least moderate shock in those contexts. So if you have a systolic BP of 100 and a heart rate of 100, that person is already starting to become shocked in front of you. And anything over 1.4 is fairly profound shock. So 140 for systolic, heart rate of 140 with a systolic of 100, in the context of a bleeding patient, we should be really quite worried about them. Okay. So, a better definition for those coming up to the exams is shock is probably well defined as acute circulatory failure. So important, we're talking about circulatory system here, associated with inadequate oxygen delivery to the cells. Okay, so oxygen delivery, as we know, is essentially your cardiac output and your oxygen carrying capacity of your blood. So humour me, and for the rest of the talk, we're going to assume that cardiac output is stable. The oxygen carrying content is stable and appropriate. So then really now we're talking about determinants of cardiac output as our factors into shock. So we have our heart rate, but then we have stroke volume and the factors affecting that, so preload, contractility, and afterload. And really, a deleterious change in any of those parameters can then lead to shock developing, tissue dysoxia, and consequences of that. Okay, fine. So then, why am I going to start talking about boilers? So shock can be further differentiated into different subtypes. This shouldn't be new to anyone in here, but an analogy I found really useful when this was taught to me was to liken oxygen delivery to the tissues to a heating system. So we imagine the healthy, well-oxygenated, well-perfused organ as a warm radiator. For the radiator itself to then stay warm, you need enough fluid to carry that heat through the system. You need a working pump to get it there. You need open pipes for that water to flow through, and the pipes need to be intact and not leaking. They're able to carry that water effectively. All right. Failure of one or more of these is going to lead to a shock state. So, first one, I think the one that's easiest for everyone to conceptualize is then hypovolemic shock. So, by definition, a loss of intravascular volume, and typically acute, but the analogy is then to a burst pipe. So the result of this is a drop in your cardiac preload to a critical level. This can, the body can compensate for about 10% loss of your total body volume, intravascular volume, by shifting fluid from the interstitial spaces. But after that, we're kind of struggling. And that's when you start to get your changing. But if we imagine all the water in the system is on the floor rather than in the system, your pipes are empty and cold, your pump's working quite hard, so you're expecting hypotension, tachycardia, and then cold peripheries. There's nothing there to perfuse it. Okay, and this is usually either due to hemorrhage, whether from trauma or upper GI bleed, for example, or a loss of kind of plasma and body water from other causes. So typically GI, can be renal losses, can be from skin. So burns is a classic cause of this, and then ascites, things like liver failure. But just like a burst pipe at home, the treatment program is simple: stop the leak, and then refill the system. And obviously, if it's blood coming out, put blood back in. If it's plasma volume coming out, we can put plasma volume back in, crystalloids, etc. You're right there, the Royal. Yeah, or was I just a bit quiet? Okay. Yeah. So next, let's talk about cardiogenic shock. So here we're then talking about pump failure. All right. So a definition again for those about to come up to the exam. So cardiogenic shock is a critical reduction of the heart's pumping capacity, which can be either due to systolic or diastolic dysfunction, but it leads to a reduced ejection fraction or impaired ventricular filling. And we can kind of think about this in one of three main ways. So this can either be due to the muscle, so the myocardium. So the most common cause of cardiogenic shock is then acute MI, but also cardiomyopathies, and then you have some others such as myocarditis, stunning post-trauma, anything there that's going to cause reduced contractility of the muscle. This could be an electrical failure. So both brady and tachyarrhythmias can cause ineffective output, either from an inefficient heart rate to support your cardiac output, or so fast you get impaired filling and ineffective stroke volume. And then the other way is mechanical. I'll touch on this in the next bit as well, but essentially anything intracardiac that's directly impeding flow. So valve disease, intracardiac thrombi, or kind of scar tissue post-MI that impairs on contractility, all of those things can be there. So obviously things like echo, ECG, potentially cardiac output studies are all quite helpful here, but then the treatment options are essentially then tailored to the cause. So if we have a myocardial issue, can I improve the muscle function by either reperfusing? So do they need to go for PCI? Do they potentially need to go for bypass? Or do we need to give a bit more squeeze? So inotropes. We could also think about reducing afterload, and things like vasodilators can be quite useful here. If it's an electrical problem, can I either revert or control the electrical system? So do they need a cardioversion, whether chemical chemical or electrical? Do they need pacing? Do they potentially need an ablation, for example? And if it's mechanical, can I clear the obstruction? So do they need to go for an urgent valve surgery, or at least a balloonoplasty, or do they need mechanical support? So that's when we start to talk about impeller devices, VA, ECMO, things like that. That's probably beyond the scope of this talk. That then kind of leads us on nicely to obstructive shock. Now, I found the definition is a little bit irritating because I think you could quite rightly make the argument that an acute valve closure or stenosis or valve thrombus is an obstructive shock in itself. But most definitions I find essentially say obstructive shock is a condition caused by the obstruction of the great vessels or the heart itself. It can present very much like cardiogenic shock, and there are, like I say, there's some clear overlaps. But what we're really thinking about is a blocked pipe. And the picture I've got here is kind of showing that's typically an external blockage we're talking about here. Well, the issue is symptoms can be non-specific, and you get those autonomic changes of tachycardia, tachypnea, but the hypertension can show quite late and can be modest, but then very rapidly progress, and a lot of these conditions will rapidly lead to arrest. You might see some congestion in the pre-blockage vessels, or altered peripheral pulses. It's like pulsus paradoxus, but the main ones we need to worry about, so you've got the classic big three of tension, so tension pneumothorax, tamponade, thrombus, and particularly PE. But there are a few other ones relevant to us, especially on ITU. So high peak ventilation, so APRV, can essentially simulate obstructive shock. And cable compression, especially in our obstetric patients, or other masses pressing on the great vessels, can then present as obstructive shock. Important from obstructive shock is it needs immediate causal treatment, which is probably why it differentiates itself from cardiogenic shock. So obviously, if there's a tension pneumothorax or a tamponade, that needs to be drained. Or if there's a thrombus, this is when we're thinking about thrombolysis in these shocked contexts. But the other ones can be quite simple. So obviously, if it's a high PEEP, we can try and turn the ventilator down. But cable compression, that's why we did our left tilt in obstetrics. And then finally, the most common, but also I think the most heterogeneous and challenging, is distributive shock. Okay, and in this case, we're really talking about pipe failure. So distributive shock is a state of relative hypovolemia, but it's due to a pathologic redistribution of the intravascular volume. So actually, your cardiac output is often normal or sometimes even increased, and then we can see that in a kind of septic state. So I'd liken it to either having floppy and or kind of leaky pipes in your plumbing system. All right, so technical term must have been for floppy vessels. There is a vasoplegia, but there's a few different etiologies. So the classic example for a tone dominant distributive shock is a neurogenic shock. So here, you typically, due to trauma, it can happen in other neurological pathologies, you get an imbalance in your autonomic nervous system, which leads to profound vasodilation, so usually from that loss of sympathetic tone. So you get profound vasoplegia, so you often have quite warm peripheries with clearly dilated blood vessels. So you've got hot water in the pipes, there's just not enough pressure to then reach the radiator and perfuse that end organ properly. Adrenal crisis can look a little bit like this as well. So you've got that. But here the shock is due to you've got decreased alpha-1 expression in patients with chronic adrenal insufficiency. So when you lose that external cortisol rapidly, they can't maintain their arteriolar constriction. And then the other ones are a little bit more mixed. So Sepsis is then the most common of the kind of mixed distributive shocks. I'm going to touch on that more. I'm just going to touch on it now because I'm talking more about this on the next slide. The other really common one, obviously, is anaphylaxis. So here it's a massive histamine-mediated vasodilation, and that causes big capillary leak. And then obviously the others are similar to this. The toxic shock kind of goes hand in hand with sepsis really here. Certainly for those at the Glenfield, post-cardiac bypass, and that kind of inflammatory response there, causing quite a lot of vasoplegia and vasodilation. But really anything that could cause a big inflammatory response will typically then present as a distributive shock. So pancreatitis, for example. So obviously the keys to management then here again is source control. So remove the trigger. So we know when we think about that for sepsis, we know when we think about that for anaphylaxis. Obviously, in the cause of spinal cord injury, that's quite hard to do in the immediate phase. Volume expansion is then helpful to a point, but this is a relative hypovolemia. So past the point, it's all that's going to happen is we're going to get redistribution and going to worsen it and worsening deleterious effects from that. So vasoconstriction is then, especially at the point that they're sick enough to come to us, becomes the mainstay of their supportive treatment. Can obviously then consider steroids as well in refractory shock. Obviously much sooner in adrenal crisis if we think that's the main cause, but for the same reason of upregulating that, those alpha-1 receptors. And that kind of brings me into then septic shock. So septic shock could very easily be its own talk. But I think it provides a really good example of the fact that although we have these divisions and subdivisions of shock, actually its most common is really going to be multimodal or mixed shock. Okay, so in sepsis and septic shock particularly, the cornerstone of your pathophysiology is endothelial dysfunction. So you get multiple varied pathologies simultaneously. So going through it from a shock point of view, distributive shock is the predominance. So you get vasodilation and leak due to the inflammatory cytokine release. And then this is echoed and compounded at the microvascular level as well. So you get changes in blood viscosity and reduced blood flow to through the microthrombi. And all this means is your microvasculature in particular is quite impaired. There's some, if you have free time, suggest you go look at some of the infrared pictures that have been taken of tons of people with sepsis, and it's quite interesting to see how those blood flows changes. They can develop a true hypovolemic shock due to the insensible losses and the autonomic response to their illness. But you can also develop cardiogenic shock. So myocardial stunning and septic cardiomyopathy is a thing that's well recognized. Secondary MI due to poor perfusion can then compound the situation as well. But also you get those cytotoxic changes. So you then get mitochondrial dysfunction, and so you'll get worsening dysoxia at the cellular level despite potentially having what would seem like adequate perfusion. So really that kind of hypertension doesn't really tell the whole story. So that's all I really wanted to go through for this. So what I'm hoping I've done is kind of given a definition of shock that I hope helps those that are coming up to an exam. Gone through our kind of classifications of that. Try to give a kind of a mental framework as a tool, certainly for the more juniors, to help kind of process the thoughts and kind of direct them there for the kind of the differentiation, and then from that bringing that towards my treatment target. So I say, okay, it's muscle failure in the heart, how can I try and make that muscle work better? And then just touched on multimodal shock. Thank you for listening. Was there any questions on anything I'd said from the floor? I don't think this is new or groundbreaking to anyone.
Hello, hi, I'm Mohammed Abada, one of the ICU trainees here at Glenfield. Today I will present for your club. The topic for today to be the combination of urinary biomarkers can predict cardiac surgery associated acute kidney injury for systematic review and meta-analysis. Why we choose this topic? Because actually the AQI is very common in cardiac surgery patient. Normally it can happen up to 50% in this group of patients. And the main problem, it will affect the mortality, length of stay in the ICU, in the hospital, morbidity, and lot of ICU complication, for example, like weakness. Okay. So the aim of this review mainly to see if we can predict the AQI quite early, because when GFR spots the AQI, normally we lost more than 50% of the nephron function. So we are trying to find another modality or other biomarkers to spot the AQI quite early, so it helps us for diagnosis and early prevention and management. So AQI for definition, so we have 3 stages for AQI. So we have stage 1, 2, 3, and for stage 1, normally creatinine will increase more than 1.5 to 2 from the baseline, or clinical parameter. We have drop in urine output 0.5 ml per kg for consecutive 6 hours. And stage 2, normally baseline creatinine will increase more than 2 to 3, or urine output will drop more than 12 hours. Or stage 3, it will increase more than 3 times from baseline, or patient still almost anemic or for 24 hours, for example. So in AQI and cardiac surgery, so we have like etiologies for simple, like any AQI, pre-renal causes, renal and post-renal. So for renal, like dehydration, bleeding, heart failure, all of this like common things can affect any patients. But in cardiac surgery, we need to check and for like cost clamping time, the bypass machine time, because more we will cause clamp will cause more hypoperfusion, more ischemia, and it will increase the risk of AQI. Also for intrinsic factors related mainly for cardiac patient, like reperfusion and injury to the kidney. When we unclamp the aorta, it will cause like reperfusion injury to kidney, and again what can cause AQI. Post-renal is very unlikely in this group, like obstructive urine catheter or mass, so very unlikely to happen in this group, but it can. So this systematic review, basically they did like a search for all studies in AQI and cardiac surgery. So they started searching from November 2022 to November 2024, and they got all of the studies related to the cardiac surgery AQI using urinary biomarkers for diagnosis. So they didn't put any restriction or any filter, just to get all of these studies, then assessed by 2 independent reviewers to minimize the bias for selection. So from screening, they screened more than 13,000 of articles and minimize it to 95 articles. This was the most relevant to cardiac surgery patients. So they included like 14,455 patients. And the inclusion criteria, so they include all of the urinary biomarker studies related to the cardiac surgery, and they included the study using area under curve sensitivity and specificity for biomarkers, and using AQI definition by the criteria we spoke about it earlier. So this is the biomarkers, so they selected like 11 urinary biomarkers for screening AQI. So actually it's quite difficult names. We have this 11 biomarkers. So I will just leave it for a couple of seconds to read the abbreviation and the markers. So Okay, so for methodology of this meta-analysis, what they did, they tried to measure the individual biomarkers itself to early diagnosis of AKI and use combined urinary biomarkers. If we use like different biomarkers at the same time for diagnosis, so this primary outcome and secondary outcome, and timing for sampling. They decide check the pre-operative, intraoperative, early, post-operative, and post-operative after 1 to 3 days. So the primary outcome to check if each individual biomarker can diagnose early the AKI in cardiac surgery, or secondary outcome to check if combination of urinary biomarkers can identify and predict AKI early or not. So for the conclusion of this study, so basically for individual biomarkers, is no, they can't find any individual biomarker can give like excellent prediction or give us area under curve of this higher number. So the maximum they can get like 0.74, so between 0.6 to 0.7. So you need at least above 0.8 or 0.9 to say this biomarkers has good prediction. So for single selection, they can't use any single biomarkers to say it's good for early prediction. And secondary outcome, when we used combination of urinary biomarkers, they found like good, you can say excellent accuracy. So around area under curve 0.84, which is more or less reasonable to predict the AKI. So the conclusion of the meta-analysis and the biomarker. So if we can use the combined urinary biomarkers, it can give us like early diagnosis even before rising in AKI. So the only thing, if these things can help regarding the outcome and cost as well, because this biomarker is very expensive and it's not available in all centers of in UK other cardiac centers.
Go down to any reformer.
Okay, so the strength points of the meta-analysis, the largest review so far to review these topics in cardiac surgery. So they included 95 studies, as we said earlier, more than 14,000 patients were included in the study. So decided to do between combination and also clinical correlation of the AKI. They tried to use some methods for selection, for example, Prisma and Waveform, to spot the bias of the studies, but we'll come to this in the weakness point. So for the weakness point, so it's high heterogeneity of the population. So a lot of diagnosis, a lot of comorbids, timing, and AKI definitions. So some studies use different AKI definitions. So again, it may dilute your data or affect the results. Some studies, we just include some studies, even they aware there's some bias, but they include it. And regarding publication bias, if there's any publication bias, they didn't even investigate for publication bias for these cases. And the most one of the important things when we aim for a study, so the quality assessment. So they basically the studies didn't relate with any length of stay in the hospital, ICU, mortality, diagnosis, or affection, comorbids. So this is one of the weakness points which need to be investigated in the future if we are decide to do early diagnosis. So we need to see exactly using this biomarker will affect our mortality, morbidity or not. So it will give us useful information if we need really to use it in our clinical life or not. And so by the end, to use like combined biomarkers still too early to answer. this question because it still need more research and more investigation to get accurate data. This is the first thing. Second thing, as I said, just to correlate this data with the morbidity and mortality in the hospital and the ICU. So these things also need to be discovered to decide if we can use these biomarkers or not. Also, we need to check the availability, the timing, easy to get the results of the urine biomarkers. So these things also need to be investigated further to decide if we can use it in the future or not. But it's one of the promising things we can. Regarding the temp factor and legal and cystatin, we can use it for early prediction, but again, it's not available in all center or not easy to get the results quickly diagnosed. So this thing's still under process for now. I think that's it for me. Any questions on my move here?
Was it like a specific combination or multiple combinations?
So the specific combinations they try to suggest between TEM2 and factor and cystatin. This is going for this combination, but again, there's no usual which combination you can use to say investigate like 11 biomarker, but this is the most relevant things we can use it as a combination.
And you said the focus was is it early detection with AK or just but also just diagnosing it as well?
Early detection.
So how early is early? It's early compared to like a creatinine.
Yes, comparison to creatinine, because sometimes you don't have like baseline yet, or sometimes it takes time to write, so just early detection, but important.
There you go.
If you can get the results quite early, so actually you can use it as an early diagnosis or not, because sometimes it will be increased, but it will come back after 1 or 2 days, so it will be useless at this point. So since we need still more investigation, we check that availability of the symptoms.